All right, perfect. Thank you, Shivani, for that excellent review of implementation. It's such a large and diverse health system there at Memorial Hermann. So now I'm going to try to share with you our experience at St. Joe Candler and through our implementation experience. And we've been up and live with this for quite some time now, about 18 months. So I'm going to talk to some of the clinical, financial, and operational benefits that we've observed with Bayesian dosing at our institution. All right, so just to give you a little context, St. Joseph's Candler Health System, we're a community health network. We have 714 beds divided between 2 anchor hospitals. Some quick stats to give you some comparison to Shivani's program there. A little bit smaller, right? We have 2 hospitals, 57 inpatient pharmacists, many more outpatient. But again, pharmacies are responsible for all of our vancomycin dosing via an automatic consult. We have 3 dedicated ID specialists and numerous College of Pharmacy faculty. All right, so our journey so far, our journey is very similar to what Shivani just described to you at Memorial Hermann. We had to go through all the same exact steps to implement AUC at our institution. And now we're in this monitoring phase, the post-implementation phase, where we're really assessing our program to make sure we're getting the intended results, the results we set out for initially. So I'm going to talk to you about how we monitor our program and the things that we've observed so far. And anytime you're defining and you're going through a monitoring program and structuring that, you have to figure out how you're going to define success. Are you setting out to improve clinical outcomes? Are you looking to gain cost avoidance and cost savings? What metrics are you going to monitor? What metrics are available to you? And this is something where we will discuss the benefits of Bayesian dosing in relation to first order kinetics throughout the rest of the slides upcoming. But there are specific metrics you can pull out for your patients to get benchmarks for your program. And then, of course, you have to know what your baseline metrics, what baseline metrics you have already. You might have to dust off some old MUE data, pull out and see where you're starting from, and to really see where you're going and the benefits you're going to realize with AUC. You want to know where your baseline is and then what the impact of AUC has been at some set intervals throughout. So a little bit about our program structure. We actually went with a web-based version instead of an integrated version of DoseMeRx. We went live a little bit ahead of the guidelines in February of 2020, right before COVID put everything into a gridlock for most people. Pharmacy is responsible, again, like I said, for 100% of all vancomycin dosing via an automatic consult. And we brought vancomycin or AUC dosing in vancomycin to all of our patients, all of our adults that are receiving vancomycin, and we have target AUC range of 4 to 600 like the guidelines recommended. And then we derive that AUC from a single trough concentration in the majority of cases. With some cases, we do recommend peak concentrations. So just some key metrics of our program, looking at how many doses we've seen so far. We didn't ramp up quite as quickly as Shivani and Memorial Hermann, the size they have there. But at this point, we've dosed about 2,500 unique patients and about 2,800 unique patient courses. So we had some repeat offenders in there, but that'll pay off. That'll come up later in slides when we're trying to determine the financial offsets from our program implementation. So why did we go with Bayesian? Well, first off, we have to get to why we chose AUC. And in about 2019, we did an MUE and it showed a 14% AKI rate across the board at our institution. And that was really concerning for us. There were, of course, confounders in there. We knew there were some things that we picked up like nephrotoxins concomitantly and IV contrast, whether these patients were high risk to begin with the obesity, critical care, things of that nature. But we still felt like that was pretty high and we had some room to improve. And again, pharmacy is doing all of the vancomycin consults at this point. So this was really a pharmacy problem. So we had to come up with a pharmacy-driven solution. And at that time, we started proposing key changes to our dosing protocols, and AUC dosing was identified as a potential solution to improve our AKI rates. At that time, the literature was emerging. There was more and more piling up that this might be the move going forward. And so we started evaluating it seriously to see if it was feasible at our institution. Historically, this hasn't been feasible. It hasn't been practical. That's why we're using trough-based dosing for so long. Well, now with the advent or the invention of Bayesian dosing and these commercial platforms, this has made it so much more feasible and practical to implement in our institution. We did evaluate first order kinetics to see if that was a good fit for us. Our pharmacists were familiar with that with trough-based dosing. We were used to the calculations, used to the estimations, but we really felt like it just was still not practical enough to implement. And we really had a goal of improving AKI across the board in all of our patients. And we knew it was going to be difficult to roll AUC out with first order kinetics in that kind of volume, patient volume. So this is where Bayesian really paid off for us. It allowed us to integrate AUC dosing almost seamlessly into our workflow, both for our pharmacists that were actually dosing vanc, but also our nurses, lab staff, and clinicians interpreting vancomycin values. It created reproducibility within our program. It improved the standardization. We'll talk about some of that and some of the results we've seen in some future slides. And then clinician confidence was huge here. With Bayesian dosing, we knew we were going to get validated calculations. As Shivani alluded to earlier, first order kinetics has some really complex calculations associated with it at times, whether you're getting it from an online calculator, something in your EMR, or even an Excel document that you've got homegrown within your institution. There's still complex calculations involved and potential errors involved there as well. And this is something that Bayesian kind of takes off the table. Once you get Bayesian, you get the information for your patients into the software. It does all those calculations for you. Your pharmacists have confidence they're getting a validated clinical result, and the clinicians interpreting these values also know that that result's validated. So it helps you implement a very individualized patient care plan in your patients. And then we didn't have a lot of data at the time, but we really felt like this was going to be a cost-effective method for us. We knew first order kinetics was going to increase our lab monitoring costs by adding peak values. We were going to have to get more concentrations. We didn't really know how many times we were going to have lab sampling errors or maybe dose timing issues as well, where we had to repeat certain lab values. So we knew that was going to increase costs further. So we felt like we could really offset some of those costs by implementing a Bayesian program there. So all in all, it made AUC dosing a lot more practical and feasible at our institution. So when we set out to bring AUC dosing to our patients, we had a few goals in 3 distinct areas: we had the clinical, the operational, and financial. Of course, we want to improve patient safety and maintain efficacy in vancomycin. I think that's everybody's motivation here. And that operationally, we wanted to do that in a way that didn't disrupt our current workflow. We didn't want to significantly change what our pharmacists were doing on a day-to-day basis, how much time they were spending on vancomycin, and we definitely didn't want to impact our nursing staff, our lab staff, or physicians as well. So improving our standardization was a huge aspect of that, and this was something that really drew us to Bayesian. Financially, the clinical patient safety and the efficacy markers there, that we knew that was going to have a financial benefit, and of course this was going to be an investment in patient safety, but we wanted to implement AUC with minimal impact on our budget, and going forward that we felt like Bayesian was the best option there, and we'll talk about why in future slides. So some of the clinical benefits we've observed since implementing, we've definitely improved our standardization, and our results have been more consistent across the board from pharmacist to pharmacist among different care settings as we've rolled Bayesian dosing out. It's got easily accessible dosing reports saved within the platform. So I talked about some of our patients, how many patients have come back in and got repeat courses. Well, I've got all of their old dosing history right there within the platform. When I go enter a new course, I can quickly review their old course, see how they performed last time, see if their clearances or their Scranton clearances are similar, if they're in a similar clinical scenario, and if that dosing probably is going to be reproducible on this time, so we can get the dosing right on the front end. It improved our pharmacist confidence. We got validated and reliable, accurate results, allowing us to focus on executing that patient care plan that we wanted to set forth to optimize those outcomes. And then it also has increased our prescriber confidence. Physicians are placing more trust in pharmacy dosing plans, and this is directly in association with that reduction in AKI that we've seen. We'll talk about some of the numbers we found in our institution a little bit later. And then in the infamous rare toxic vancomycin levels, our nephrologists are much more hesitant to blame acute kidney injury on vancomycin these days than they were, let's say, 2 years ago. But those are all like anecdotal feel-good stories. Those are things that we've observed. That we want some hard metrics that we can report back when we implement and spend and invest in implementing AUC. You got to come back and report some real hard data to your appropriate committees, whether it be the C-suite administrators or something like a pharmacy and therapeutics committee. Well, this is where Bayesian has a clear leg up over first order kinetics. You've got all this data within your platform, and they can help produce hard benchmark metrics for your dosing program at your institution. So these are some of the options that you can pull out in DoseMeRx, for example. And we'll talk about how you might use those to develop them and refine your program along the way. So these are results in our program, actually. So we're looking at serum creatinine increases. That's in the 3.3%. That's a big reduction from that 14% or so we saw in that MUE. I told you we presented PNT in 2019. And this is some of the interpretations that DoseMe would kind of generate for you, is that very few patients have those increases, serum creatinine increases while on therapy. Very few doses are given a AUC above 600 within our program. This is something that was reassuring to see. And then some other metrics they can pull out related to efficacy. You can see how fast or how often your patients are getting to a therapeutic concentration, and then at what time interval they're getting to it. So for the majority of our patients, our goal was to get our doses optimized at the 48-hour mark in the majority of our patients. And right now we're currently meeting that at about 87% of our patients. Very similar to what Shivani was showing you earlier, where Memorial Hermann hitting it about 89% of their patients. But here's the thing, let's say we wanted to get to 90%, and we do. So what we're doing at our institution now is utilizing DoseMe to identify these patients that did not reach their therapeutic AUC in that time frame, and we can actually specify and get patient-specific information for our problem patients that aren't getting there, pull them right out of the platform, analyze what's going wrong there, find a solution, and fix it directly. This is very unique and something we would not be able to do with first-order kinetics. Operationally, when we implemented with DoseMe, it ensured that all of our pharmacists were getting their AUC estimates from a uniform source. We had a variety of trough-based practices. Previously, some pharmacists were pulling out calculators and doing the first-order kinetics by hand. Others had Excel documents built. Others were using an online calculator of some sort. So now we're getting all of our results from a single place, all of our calculations from a single source, and it's giving us validated results. So this was huge for us and improved standardization across the board. Rolling out Bayesian and dosing and AUC dosing with DoseMeRx allowed for implementation with fewer VENC assays, which greatly reduced the impact on our nursing and lab staff. And this is what really allowed us to bring AUC to all of our patients. I don't know that we could have brought AUC to everyone had we had to do first order kinetics due to the incremental costs associated with it and the time constraints that would have been associated with first order kinetics. So this is something, a huge selling point for AUC for our institution. We still do trough-based dosing to determine our AUCs. So prescribers are still seeing that customary trough. They're not having questions about what's going on. We're not seeing random levels as often. We're not seeing peaks as often. So we're not confusing our prescribers that are used to seeing troughs. We're not changing too much on their behalf, and it's really not changing anything for our nursing staff as well, because they're used to drawing troughs right before they give a dose. So by doing this and reducing that impact on our nursing and lab staff, it allowed us to reduce our education needs. It wasn't as intensive education needed for our nursing or lab staff or our physicians. We could focus that into that education on our pharmacists who are actually managing the vancomycin in our patients. So that allowed us to roll out AUC with a little more focus on clinical concepts and utilization of the software. And this is some useful data that you can pull out of a Bayesian platform, specifically DoseMeRx here. This is something we haven't had before. We can get clinician-specific data. How are you performing? How often are you using the software? How many patients are you dosing there? You can identify your top performers, your people that are integrating AUC within your institution most often. You can figure out what issues, if any, they're having. You can figure out how they've worked around those and integrated that into their workflow. And then you can take those solutions that have been proven at your institution and take those to somebody who's maybe not performing as well, not integrating AUC into their practice as easily, and try to help them facilitate solutions to maybe raise up your average in standardization across the board. So that's something that's pretty cool and unique to Bayesian dosing here, and it's something we haven't fully implemented at our institution. We're still working on this and how to use this data. This is interesting because we haven't had this before. So after we implemented AUC, we decided to do a post-launch assessment here. We wanted to evaluate our dosing practices. We compared trough versus AUC dose patients, and we tried to do a case match here, and we'll talk about how we did that. We had some unexpected findings early with that. And, there was clinical uncertainty in the immediate transition period. Like Shivani said, there's definitely a transition period where you're going to have to monitor and make sure everyone's interpreting your protocol as you intended. As you see, we had fewer peak concentrations than our protocol recommended in some cases. And then AUC group, ironically, had more troughs in their goal range than our trough dose group. So from that, we dug a little deeper. We wanted to understand where that clinical uncertainty was coming from, because we noticed it in our pharmacokinetics notes. And it really dove down to an oversight on our part when we rolled out education. We really focused on AUCs. We really focused on the platform, how to interpret that information, and make sure they were comfortable with Bayesian kinetics there. But we didn't focus so much on the PK parameter estimates. Our pharmacists were very used to and had very good clinical experience dosing patients on first order kinetics and population estimates. And from that, they were calculating their own population estimates, comparing it to what DoseMe was generating, and saying, well, I don't know if I want to trust DoseMe in this case because I got a different creatinine clearance estimate. I wouldn't calculate that creatinine clearance in this patient. And then we saw them use different doses or alternative doses from what DoseMe was recommending, and we found that they were more likely to have subtherapeutic AUCs. So it was something we had to re-roll out and really educate on the differences in where these PK parameter estimates are coming from within the platform versus population kinetics there. And so this was a national survey we did as part of that post-implementation assessment. This is something we published as a letter to the editor, our team did earlier this year. And we were really looking at transitioning from that guideline approval to practical implementation. We knew this was something that our facility, went through a process. It was difficult, it was a long process, but definitely worthwhile. But we wanted to figure out where other people stood with that. And we were surprised to find that 18% of respondents at that time, and of course this is May and June of 2020 in the heat of COVID, but 18% of respondents stated they had plans to continue trough-based dosing. They had evaluated AUC to some degree and decided to stick with trough-based dosing. And we just wanted to know why. We didn't fully formally capture that in our survey, but some people actually reached out to us, and we found a trend that many were, just very concerned about the ROI on this. They were looking at the financial aspects. They looked at their current AKI rate and decided, hey, we're at a comfortable level. We like where we're at. So we're not really going to look to implement AUC at this time until some more data is out there, some more data is available. So we're going to talk about what financial data is out there in terms of return on investment, and specifically in relation to AKI. So how do you get that necessary budgetary support, right? We've got the clinical benefit that's well elucidated in the literature now. The operational benefits are there. If you look at Bayesian, how seamlessly it can be implemented at your institution, it's there. It's a very attractive option. But then financial approvals always seems to be the hiccup. That's the question I get the most from other institutions that are going through this process. And how do you get that justified? So one of the things that really worked out for us was you have to know where your current AKI rate is in your patient population that you're intending to bring AUC in. If you're bringing AUC to all your patients, you want to know your AKI rate across the board, right? But if you're looking at targeted populations, you need to know what your vancomycin-associated AKI rate is in those targeted populations. And at that point, you can estimate a cost savings with a very conservative 50% reduction in AKI. So looking at that, that's pretty standard across the board in the literature. You can see a nice 50% reduction, but some had a little bit more than that. So I think 50% is a conservative measure. And at that point, there's a number of cost savings or associated AKI cost data out there now that you can generate a cost savings estimate from. And then you can decide from there, is Bayesian or first order kinetics the right way to get there? Is that going to be the best way to implement that to the fullest? And when you're talking to your finance department, you're trying to get budgetary support, you have to speak their language. You can tell them Bayesian is it's a fixed cost. You can plan for it, you can budget for it year after year, and it's irrespective of patient volume. So no matter if I dose 5 patients or if I dose 500 patients in a month, I'm going to pay the same fee. So first order kinetics, that's not the case. If you want to roll this out to maximize the benefit of bringing AUC at your institution, there's uncertain incremental costs associated for every single patient, right? You're adding vancomycin assays, you're adding unknown impacts on nursing time, lab time, pharmacist time, and then clinician interpretation issues as well. So this is something we knew we struggled with, and in terms of troughs, when even trough values are tough to get at sometimes and appropriately timed in clinical practice. And adding a peak to that, we thought that was just going to make things even more difficult for us, and the potential for repeating and redundant labs is astronomical there. So continuing on with that post-implementation assessment that we did, we also included a financial analysis in that. And so a little more specifics, we had 100 patients in each group. We case matched based on demographics, Charlson Comorbidity Index, as well as ICD-10 codes to identify them. We had a trough group and an AUC group. You can see the time frames there, and then our definition for acute kidney injury. So some of the interesting results we have, this was a student project that we presented a poster on at mid-year this past year. We had some interesting findings come out of this. Our AUC group had a little bit longer length of therapy there on average, and there's 100 patients, but number of dose changes tended to be fewer in those AUC groups. Troughs were actually in range more often than in the trough targeted group, which was ironic to find. We saw our average trough come down, which is reassuring to see. That's what you kind of would expect to happen when you implement AUC. But the big thing here, this is beautiful, reduction in nephrotoxicity at our institution. We started off with 12% in that trough-based group, which is very similar to that 14% we saw in the MUE data, and we cut that down to 2% in this study with the AUC dose group. And this is huge. We saw a big patient safety impact, and that's exactly what we were shooting for when we implemented this. And so seeing those results is very reassuring and big time confidence building for our program. And then the other thing is the average cost per patient day is net neutral here. You're looking at about $16.50 for trough and $16.20 for AUC. So this was awesome and reassuring to see that we implemented with a net neutral impact on average daily cost for vancomycin dosing. So how did that translate to us financially at our institution? Well, first off, the Looking at the AKI rates we saw in the trough group, comparing that with the AUC group, we got 12 versus 2%, and that was statistically significant. So that was 6 times higher in the nephrotoxicity in our trough-based group. And you can see the estimated cost reductions here. And this is based on a study by Patel and colleagues published earlier this year. They found that a single dose of vancomycin-associated nephrotoxicity was an extra cost of about $8,000 when you considered specialist consultation, length of stay, and all the things associated with an AKI, especially if you get to the severe cases where dialysis is concerned. You know, so the impact at our institution is potentially massive right there. You're looking at about almost $2 million in net return just from the safety offsets. So this is a huge, huge number that we can consider. And I can assure you, it definitely offsets our Bayesian dosing budget. But let's say you don't remember, you don't actually believe that number. Let's say that AKI rate you think, or the AKI cost of $8,000 seems a little high to you. Let's cut that number in half. What if it's $4,000? If that's what every AKI costs your institution? Well, great. That's still $1 million in cost savings. Those are still very significant financial numbers. And we can do that math and we can keep going down over and over again, and it still proves to be very, very beneficial financially and completely can offset the cost of a Bayesian platform. So to conclude, some of the do's of the definite things we want you to consider when implementing and learning from our experience, definitely consider how Bayesian dosing can meet your dosing and your monitoring needs. It's really cool, some of the data you can pull out and monitor your program, keep benchmarks and making sure you're hitting the goals you set out for. Pick metrics to monitor your most important goals at your institution. You know, everybody's rationale or AUC implementation is unique, and so make sure you're picking the goals and metrics that most accurately represent those goals. Communicate your success stories early and often. This improves provider and clinician confidence, those that are actually managing vancomycin patients and utilizing AUC dosing. If you communicate those success stories early, showing that, hey, we are actually seeing those reductions in nephrotoxicity, you get increased clinician buy-in. Provide open lines of communication for stakeholder feedback, making sure everyone can communicate issues early and often and effectively if there are any that arise, so you can come up with solutions in real time instead of waiting on things to progress and having to catch major issues that could have been prevented. And then, of course, continuously utilize data to refine your process. This is where Bayesian has a clear leg up on first order kinetics. You can really pull some unique metrics out of there and really determine where you are as a program and where you want to be, and pull out patient-specific issues to help you get there faster. Some general don'ts. First thing is don't take for granted. Monitoring for granted when you're evaluating Bayesian dosing is an amazing benefit of Bayesian. Don't assume that AUC or Bayesian dosing is too expensive to implement without evaluating those potential cost savings to your patients and to your institution. And then don't underestimate the financial impact of AKI reductions and how much that can have at your institution. That was something we definitely didn't expect to see that large of a financial offset at our institution, but going through this, it's something that's been a massive benefit to us. And for that, I want to conclude and thank you all for the opportunity to present and turn it back over to Christy for questions.